minute for me to run something by you?
Of course. What is it?
My patient is a 29-year-old prima gravida, 34 weeks pregnant. She was at home when she suddenly felt a large gush of fluid from her vagina. I'm concerned that her membranes might have ruptured.
Are there any signs of labor, Diane?
No, she's not having any contractions. Should I check her cervix to see if she's dilating?
Yes, that's a good idea. We can check her cervix to make sure she's not going into labor, but it's very important that we use a sterile speculum in cases like this, rather than manually checking. It sounds like she might have had a premature pre-labor rupture of membranes, which is when the amniotic sac bursts before the pregnant person goes into labor. It's considered premature if it happens before 37 weeks. Because that barrier has been compromised, there is a risk of infection.
Well, this might be a silly question, but how do we know for sure that the leakage isn't urine?
No, that's actually a good question. Urine leakage during late pregnancy is common, which is why we have tests we can use to differentiate. We can use nitrazine paper to check the pH of the fluid. Amniotic fluid has a higher pH than urine or vaginal fluid, which will turn the strip blue. We can also get a sample of the fluid to send to the lab to check for ferning. When you look at amniotic fluid under a microscope, it actually makes a fern-like pattern.
So if it does turn out that her membranes have ruptured, what are the implications of that?
Well, there are several things that could go wrong. Like I said before, a main concern is infection, and the one we're primarily worried about is a uterine infection called chorioamnionitis, which is potentially life-threatening for mom and baby if sepsis occurs. The baby could also develop meningitis or pneumonia while still in the womb. Besides infection, remember that there is less fluid surrounding the baby now. There is actually a term for that.
Oligohydramnios?
Yes, oligohydramnios is a concern because without enough amniotic fluid, the baby's lungs can't develop properly. We call this pulmonary hypoplasia. Limb defects are another concern because, as you can imagine, without all that fluid to float around in, the baby is bumping into the sides of the uterus. Another big issue is that the umbilical cord could get compressed and the baby would be starved of oxygen.
Oh, clearly I need to go and check on this patient right away. What type of nursing assessments should I be doing?
You're right, it's urgent because our next steps will depend on our assessment findings. First, we need to ask ourselves if there are any signs of infection. We need to assess for uterine tenderness, fever, and elevated heart rate. We'll also collect a blood sample to monitor white blood cell levels. And then we can do a vaginal swab to rule out STIs, group B strep, and BV. While we're doing this, we can also check for cord prolapse. And of course, we also need to make sure the baby isn't in distress by monitoring the fetal heart rate. It should be within the normal range of 120 to 160 beats per minute. If, after all this, there are any concerns about infection, the baby's well-being, or issues with the cord, then delivery will need to take place right away, since these risks outweigh the risks of prematurity. So let's go check on our patient.
Okay, I've done my assessments and mom and baby seem to be stable. There was no cervical dilation, no cord prolapse, and no signs of infection, and fetal heart rate is 145. Dr. Ng is sending her home on bed rest to give the baby more time to mature and develop before delivery. I need to do my discharge teaching. What should I review with her?
You want to make sure that she's looking out for any signs of infection. She should check her temperature every 4 hours and call the doctor if it's 38 or higher. She needs to report any foul-smelling vaginal discharge and definitely make sure she knows that it is important that nothing go inside the vagina. That means no intercourse, no baths, etc. You can also remind her to wipe from front to back when she goes to the washroom. Another thing you can teach her is how to do kick counts, where she relaxes in a reclined position and counts baby's movements. She should do this every day, and she's looking for 6 movements in 2 hours.